Good afternoon, and welcome to the Johns Hopkins 30-minute COVID-19 briefing, where we'll provide live insights from the experts who lead our work at the Johns Hopkins Coronavirus Resource Center. We know that everyone is busier than ever and trying to make sense of these unprecedented times while balancing work and caregiving and so much more. So our aim is to make these briefings quick, clear, and to the point. We'll focus on what you need to know right now about the COVID-19 pandemic and public health responses. As part of this briefing, we'll have an opportunity for live Q&A with our experts. We'll be offering these 30-minute briefings regularly on Fridays at 12 p.m. I'm Dr. Lainie Rutkow, a professor at the Johns Hopkins Bloomberg School of Public Health, and I'm part of the leadership team for the Johns Hopkins Coronavirus Resource Center. I'll moderate these briefings, and I'm excited to connect you with our experts. We'll be providing answers today in real time, so please submit your questions in the box at the bottom of your screen. Today, I'm joined by two guests. Beth Blower is Executive Director of the Johns Hopkins Centers for Civic Impact. Beth will provide an overview of national COVID-19 data trends and state-level public policy responses. I'm also joined by Dr. Bill Moss, who's the Executive Director of the Johns Hopkins International Vaccine Access Center and a professor at the Johns Hopkins Bloomberg School of Public Health. Bill will give an update on vaccine development and policy responses. First, I'll turn to Beth. Beth, news this week about COVID-19 trends has been quite sobering. Could you walk us through the key data points and tell us what they mean?
Sure, thanks. I'm going to go ahead and share my screen so that you can track along with me as I take us through the data that we've been looking at over the last several weeks here at the Coronavirus Resource Center. I'm Beth Blower. I help also with Lainie lead the CRC and specifically work on the data side of the site itself. The big news continues to be that the United States is leading in this COVID outbreak. As we have set into the colder months in the United States, up against the landscape of many other much more population dense countries, we are still outpacing all of the other countries globally for the rate and rapidity of the spread of the disease. We are at some incredibly high case numbers, the highest that we've seen since the beginning of the outbreak, with 187,000 cases most recently, but we're rounding on 12 million cumulatively. We're at 11.72 million right now for cases, and we hit that very sobering high of total deaths of 250 this week, and that continues to climb. The United States in November will record, and we're not even 3/4 of the way through the month, its highest case data since the beginning of the pandemic. The death data is not tracking in the same way, not breaking the same types of records as the case data. And there are a few reasons why we think that that's happening, mostly because what we're seeing now is a much younger, a spread in much younger populations, where in the spring we saw the outbreak really focusing on older populations and also populations that were not only older, but in those congregate care living arrangements, which exacerbated some of those really bad outcomes. But we are still seeing bad outcomes across the board. One thing to note is that cases are rising everywhere. Even though we see some of this data showing slight decreases, like in South Dakota and Iowa here, cases are still at very high levels in both of those places, and in the places even where we're in a steady state. All the other orange that you're seeing on this data visualization is cases on the climb. And so this is, again, another sobering confirmation that we are very much in the middle of this pandemic, and we are in a very critical moment as we continue to see the spread of this disease. And this looks a lot different than it did in the spring. In the spring, if you recall, our the case concentration was on the coasts. We are now seeing the pandemic really significantly hitting hard in the Midwest, in the central portion of our country. This is not happening in population centers where we have really comprehensive health infrastructure. This is a pandemic that's hitting very hard in rural America. And that is having a real devastating effect. And it's really stretching our capacity from a health response. If you look at the top counties, and this is cumulative data, so this is over the course of the entire pandemic, we're now seeing rural America moving into these positions as we look at these based on population adjustments, that rural America is being very hard hit. These are the top 10 counties, cumulatively, again, population adjusted, of where we're seeing case growth. And again, here we are again, really representing that rural part of the United States, our counties where we're experiencing deaths. I want to dig a little bit deeper into this. This is a dashboard that you can access from our map from Bon Homme, South Dakota. And I want to just call out a couple things. The first thing is here. Between yesterday and today in Bon Homme, South Dakota, there were 20 new reported cases. We're talking about a county that at best has 45 beds that they can offer to patients who really suffer the most severe outcomes of this disease. Only 8 ICU beds, which also is a limitation on how they're going to be able to respond. This is a critical moment for this country, and this data is continuing to report and show up in this way, that our health infrastructure is not going to be able to meet the demands of this disease. This is just in the last 7 days, where we're looking again at these rural counties that are really don't have the kinds of nursing and the kinds of therapeutics and the kinds of access to care that patients who get really sick are going to need. And again, these are the places where people are dying. This is, and you can see Bon Homme, the South Dakota county, showing up in this top 10 list. This is just another reminder that we are really having to diversify the way that we're responding to the disease. One of the big areas where we are consistently looking and calculating is in test positivity. This is test positivity for the United States. We kind of enjoyed a period of time towards the end of the summer, early fall, where we were closer to that 5% range that WHO recommends. But the data is now showing that we are at the 10% range, so sort of double where the WHO recommended line is, and that's growing and increasing. What is it telling us? It's telling us that we don't necessarily have that testing capacity to get a full understanding of where this disease is and how it's impacting communities, and that we need to do a better job at getting more testing and access to testing. The number one public health intervention that we have right now is public policy. In the absence of a vaccine, it is the action of our public policy leadership that is going to really determine whether or not we're going to be able to have an impact on outcomes that we see. Our depictions of different policy decisions. And when I talk policy decisions, I'm talking about mask mandates, I'm talking about school closures, I'm talking about business opening and closing. These are the ways that we're going to be able to control this disease. We need strong leadership at the public policy level, and we can have an impact. So you see here in a place like New York, where they're doing comprehensive reviews of policy, really trying to make sure that they can contain the disease, that they're able to have some slowing effects, or at least have some impact. And when things start to really peak, you're going to look for more restriction. You're going to see leadership that's going to restrict movement, that's going to keep people in activities that are high risk. California, you see, also use some of those policy levers to try to contain early on in their outbreak, and now they're revisiting some of those decisions around how much public life is acceptable in the light of growing cases. Where we're not seeing a lot of public policy leadership, we are seeing unchecked case growth. And again, these are in places where we know people are dying and people are getting sick. And so what we're trying to call out here is a real need for leadership and some continuity of the way that we're advising our residents. If anything, what these charts are telling me is, please don't travel for Thanksgiving, stay home, and don't give into that kind of quarantine fatiguing. So that is kind of where we are with the data. I'm looking forward to answering any questions, and I'm going to hand it back over to Lainie, who is going to introduce us to Bill.
Thanks so much, Beth. Before I turn to Bill, I want to remind our audience, please submit questions for our experts. After Bill provides an overview on vaccines, we'll quickly transition into Q&A. Bill, the news from phase 3 vaccine trials this week has been a bright spot. It seems like there are several companies that do have promising findings. Can you help us to understand the implications of that news?
Yes, it has been quite a week, Lainie, with COVID-19 vaccines. On Monday, we heard preliminary results from the Moderna phase 3 trials. This is a messenger RNA vaccine, a novel vaccine platform. On Monday, they reported vaccine efficacy of 94.5%. They had enrolled about 30,000 individuals, participants in their trial, had 95 cases of COVID-19. 90 of those occurred in those who received the placebo vaccine, and only 5 in those who received the messenger RNA vaccine. They had 11 severe cases, and none of the severe cases were in the vaccinated group, the messenger RNA vaccinated group. Then on Wednesday, we hear the results from the Pfizer BioNTech messenger RNA vaccine. They're reporting very similar vaccine efficacy, 95%. Importantly, 94% vaccine efficacy in adults over the age of 65. This is going to be very critical for for monitoring vaccines going forward. We want high vaccine efficacy in the most vulnerable populations. They enrolled 44,000 individuals into their trials. Again, half got the messenger RNA vaccine, half got the placebo vaccine. They had 170 cases of COVID-19 in their groups. 162 of those occurred in the placebo group, only 8 in the messenger RNA group. They had 10 severe cases, only 1 in the messenger RNA vaccinated group. These are really astonishing vaccine efficacy numbers, far beyond what most people expected. And then the news today that Pfizer is submitting an application to the Food and Drug Administration for an emergency use authorization. That's going to need to go through all the vaccine trial data will need to go through independent review, but we're anticipating that the FDA will issue an emergency use authorization in early to mid-December, and then there'll be vaccines ready to go. One of the things that's really accelerated this process is the concurrent manufacturing during the phase 3 trials. And these companies say they can provide enough doses for about 22.5 million Americans by the end of this year. We're still waiting to hear on the formal allocation process, but we think these vaccines will go, this initial tranche of vaccines will go to healthcare workers and high-risk individuals, particularly older adults in nursing homes. To put this in context, there are approximately 20 million healthcare workers in the United States and about 1 million older adults living in nursing homes. These findings have enormous implications for other COVID-19 vaccines that also target the spike protein. And also, I think very excitingly, this may be a platform for future pandemics and for other vaccine preventable diseases. Now, there's a lot that's not known. We do not yet know the duration of protection that's conferred by these vaccines. That's going to require further follow-up. We do not know whether these vaccines actually prevent infection and transmission of the virus, or what we're learning from the phase 3 trials, or whether they prevent disease. That's going to need to be studied. And we still won't know the long-term side effects of these vaccines. That too will come out in longer term follow-up. Are these the ideal vaccines? Well, we'll have to see. There are many vaccines in the pipeline, 87 in preclinical trials, 54 in clinical trials, 13 in that late stage phase 3 trial. So there are a lot of vaccines in the pipeline, and there may end up being vaccines that are better overall or for particular subgroups coming along in the pipeline. What's the ideal vaccine? We want it to have high efficacy. We want it to have a long duration of protection. We want it to block transmission so it shuts down the pandemic. Ideally also, it would be single dose. The messenger RNA vaccines, the Pfizer and Moderna, require 2 doses. We'd like to have a single dose vaccine. And importantly, we'd like to have a vaccine that's more heat stable. There's been a lot in the news about the cold requirements, the ultra cold requirements, particularly for the Pfizer vaccine. So if we had a more heat stable vaccine, that would be ideal. There are a number of challenges ahead, even when we have an emergency use authorization and a vaccine is available. We have to work through the allocation process. Who's going to be prioritized? We're anticipating a meeting on Monday, November 20th, of the Advisory Committee on Immunization Practices that will lay out at a federal level what that allocation process should be. And the states will be the ones and local jurisdictions that are implementing this. We have huge logistical challenges in distributing these vaccines, not just because of the cold chain requirements, but in large part due to that. But we're going to have to get a huge volume of vaccine out to a large number of people very quickly. We're going to need to track doses. We're going to need a data management system where we know who got which vaccine. People need 2 doses. We'll need to know which vaccine to give at the second dose and be able to send reminders. We need to have the vaccine accepted. We know already that in the United States, maybe 1/3 to 1/2 of people in different communities say they won't get it, at least initially, a COVID-19 vaccine. We need intensive communication strategies right now to build that trust so that people actually accept this vaccine. We need to continue to convince people to wear masks, physically distance, wash hands, and avoid large gatherings, as Beth said, as this pandemic is exploding. And lastly, we need to be able to counter misinformation and disinformation that I know we're going to face as these vaccines are rolled out. People are going to have bad health outcomes after they receive a vaccine, even if it's not related at all to the vaccine, because of the populations that we're targeting: older adults, people with comorbid conditions. So we need a communication strategy, and we need to be able to combat misinformation and disinformation. Thank you, Lainie.
Thanks so much, Bill. We're now going to transition for the remainder of this briefing into live Q&A, and I want to thank all of the members of the audience that have been submitting questions, and please continue to do so. We're keeping an eye on them, and we will get to as many of your questions as we can in our remaining time together today. No surprise, Bill, we have received many questions about vaccination and a COVID vaccine. So let me start with you. Can you speak to the inclusion of children and older adults in the vaccine trials, and what does that mean? How are each of those groups defined?
Yes, so who's included in the clinical trials is a critically important question, and it includes different age groups, but also different racial and ethnic populations and communities. So older adults have been included in the clinical trials, in the phase 3 clinical trials. This is usually defined as those adults over the age of 65. But we're going to also want to know how these vaccines work in adults over 70 years in specific older groups. Children above the age of 12 are beginning to be enrolled into some of these clinical trials. The way this kind of typically plays out is that adults and older adults are included first, and then we slowly kind of make our way down into younger and younger children as we study these vaccines in the trials. But I also want to highlight, it's very important that communities of color participate in this. In the Pfizer vaccine, for example, they had 20% Latinx populations in their trials and 10% Black communities. And that's critically important. They actually paused their trial to ensure that they have representative diversity in the trial. That's going to be really important going forward.
Thanks, Bill. Here's a question that I know is top of mind for all of us. When can we expect a COVID vaccine to be available to the public, and what exactly does that mean?
Yes, and that is a very important question and a frequently asked question. And it depends upon what you mean by the public. And so, again, we're going to hear from the Advisory Committee on Immunization Practices, hopefully on Monday, about how we need to prioritize the limited amount of vaccines that are initially going to be available until we have large volumes of vaccines. So this will be a prioritization or allocation process. As I mentioned, it'll probably initially involve healthcare workers and those who are most vulnerable for severe disease. But as we get more and more vaccines, and that's going to happen over the first few months, 3-4 months of 2021, there will be more vaccine available to those who need it and want the vaccine in the United States. And people are guessing, and including my guess, is that perhaps by mid 2021, maybe later, if mid 2021 is an optimistic projection, assuming there are no problems with vaccine manufacturing, that we will have a number of different vaccines to choose from, as well as sufficient doses to really begin reaching all those in the United States in the general population who would like to be vaccinated.
Thanks, Bill. Another question for you. Again, no surprise, we're getting a lot of questions related to vaccines. Can you speak a little more about the considerations that employers will have relative to their employees once a vaccine is available? You've talked a bit about allocation. Can you say more about what we know so far?
About the allocation process. So, and then employers specifically. So the framework, I'll say, for the allocation process in the United States, I think will be driven in large part by a very comprehensive review by the national academies that lays out the ethical principles, the procedural principles, so guiding principles on setting an allocation, and then what they call different phases, that this is going to be phased in over 3 to 4 phases. The CDC has 3 phases, so we get more and more of the population. What that is really built around are risk factors for exposure, risk factors for severe disease, and the implications on larger society. We want to be able to protect healthcare workers and frontline workers, not only because they're at high risk of exposure, but because our society really depends on those people, those frontline workers. Now, employers will be able to, once sufficient vaccines become available, we'll be able to recommend vaccines to their workers. There may be some employers in which actually vaccination may be mandatory. So for example, healthcare workers who have frequent contact with patients. It may be, as we have a precedent with influenza vaccine, that those healthcare workers need to get a COVID-19 vaccine. Maybe it's in industries in which the prevention of transmission is just so difficult. We have had large outbreaks, for example, among meat packers. So maybe there will be guidelines on protecting those populations as well.
Thanks so much, Bill. I want to now shift gears, and Beth, I have some questions for you related to data and how several questions from folks who are thinking about travel or seeking to better understand the state of the pandemic in their state or locality. Can you address how our site can help them and the different opportunities to find data?
Sure. So I'm going to first start with a strong affirmation of the guidance that the CDC put out this week saying, don't travel, stay home, stay safe, stay particularly during what I know is going to be an increasingly hard time to be away from family and loved ones, but this is not the year for a big celebration. But that being said, if you do have to travel, if you are thinking about making decisions, the places that I would certainly look on our website are to look at what's happening at the most local level. So if you are traveling to a county, you can look at the county data that will show you exactly how the cases are growing or restricting in those counties. But I urge everyone to also look at the capacity of the healthcare systems in the places where you're traveling. If you are traveling to visit family and they have a steep increase in cases in those jurisdictions and a limitation on access to a hospital or to that sort of frontline healthcare that you're going to need if you get caught off guard by this disease that can happen very quickly, I encourage everyone to look at that. And you can find that in the US map. Our dashboards are there for every single county. You can get a sense of that capacity, and also you can get a sense of the most current data around the progression of the disease. I also think it's worthwhile to check the policy tracker. The last kind of set of slides that I shared have all of the policies for all of the states, and that includes whether or not they have travel restrictions from other states, and whether they have implemented any kind of travel bans, or whether or not they also are encouraging or requiring testing if you're going to go in and visit those places. And so you can get all that information in the policy trackers, and also you can link them back out into the states themselves. So,
thanks, Beth. Follow-up question for you about how the data on our site appears. So sometimes we're hearing from folks that they'll see either a big spike or a big dip in their state's numbers on our site, on the Coronavirus Resource Center. Can you talk about the differences in how states report their data and then how that works relative to our site?
yeah, it's a great question. And we have to remind ourselves that all of the data that we're using in the CRC is pulling from government data resources. So when a state updates their data, we are pulling that in and we're going through a process, and then we're getting that data into all of the different visualizations that you can see on the site. Some states don't report every day in the same way. Some states will not report over the weekend, and then they'll push a lot of data on Monday. So you'll see artificially high data at the beginning of the week. You'll see some of that equalizing throughout the week, but then you'll see a little bit of a dip in the weekend. Some states will only report every few days, and it's not necessarily consistent around both cases, deaths, and testing, the three sort of chief areas where we're looking for data. Also, sometimes they'll change the way they think about it, particularly around testing. We've seen a lot of changes in the way that states think or about reporting that data. And when they go back, sometimes they'll correct historical data, and that could also push into some of the analytics. On the site, you'll be able to see where we've had those sort of data interruptions with some details around what that means, what we found out when we dug into that data, so that you can see the anomaly, but also kind of the justification for why it's there.
Thanks so much, Beth. Bill, very quick final question to you about vaccines. Anything that could happen that might hold up the EUA that you mentioned?
Yes, I don't anticipate it. I mean, what we're hearing from both companies, Moderna and Pfizer, certainly the vaccine efficacy data, so that certainly wouldn't hold it up. That greatly exceeds the 50% threshold that the FDA originally set. And we haven't seen the safety data yet, but what we're being told by the companies is that both vaccines are safe. And so that's at least in the short term. There certainly have been side effects, and there people have complained of fatigue and some headaches. So there are those kind of reactions that reflect the inflammation due to the vaccine. But I don't see anything really holding up the emergency use authorizations for these two vaccines.
Great. Thanks so much, Bill. I'm going to wrap up now, and I want to thank our two experts today, Beth Lauer and Bill Moss. And I also want to send a big thank you to everyone who joined us and those who submitted questions for our experts to answer. And I also want to thank those of you who submitted kind comments to us. I've seen those coming in as well. This briefing will be archived, and it will be available on coronavirus.jhu.edu. As a reminder, we'll be offering 30-minute briefings on Fridays at 12 p.m. regularly. And in each briefing, we will focus on what you need to know right now about the COVID-19 pandemic. And we will have live Q&A with our experts in each briefing. We won't have a briefing next Friday due to the Thanksgiving holiday, but I'll look forward to seeing all of you at our next 30-minute briefing, which will be on Friday, December 4th at 12 p.m. Thanks so much, and stay safe.